Bismillah ar-Rahman ar-Rahim. I really want to thank the Rheumatological Society for inviting me on this August meeting. And for a long time, I have been working with rheumatologists of Lahore and looking after their patients who are being managed for different type of rheumatological disorders, and sometimes they get eye problem due to the disorder or the side effects of the drugs they have to take in. This is the place where I'm working these days. I'm working as a professor of ophthalmology as well as principal of Sahiwal Medical College, a very fast growing medical school where M.B.B.S and postgraduate medical and nursing education is being imparted. Rheumatological disorders, they have 4% of the patients who need at the moment, referral to the eye specialist. But I suspect that the actual number may be a lot more than that. And the commonest disorders they are facing is the dry eye, uveitis, and scleritis. And we are all familiar with the Sjogren syndrome, which is a combination of dry eye, dry mouth, and a connective tissue disorder underlying. This is exact in the exact terms, it should be called as secondary Sjogren syndrome because there are people who only have dry eye and dry mouth without connective tissue disorder. And you can imagine that this is the typical appearance of these people. They've got eye discomfort, fatigue, dryness, and occasionally discharge, blurring of vision, photophobia. And in our local Pakistani terminology, they call it radak in the eyes. And it sometimes feels like there is a lot of sand in the eye, and they sometimes fiddle with the eye, trying to remove some particle from the eye. These are the signs one can examine. Obviously, an ophthalmologist would easily pick up these, that the tear film height is decreased and there is a lot of debris in the tears, and there conjunctival hyperemia. And sometimes the conjunctiva itself is loose. We call it conjunctivochalasis. We can measure it by Schirmer's test strips, and a secretion of less than 5 millimeters is regarded as the sign of dry eye. And we can also assess it on the slit lamp by using a fluorescent dye and measuring the breakup of the tear film. And there are a lot number of other dyes available, but unfortunately not in Pakistan. So mostly we rely on tear film breakup time. And this is how we do the measurement at Schirmer test strip. That is, secretion less than 5 millimeter is a definite diagnosis of dry eye. And these days, there are a lot number of other factors which aggravate the potential or borderline dry eye, which is like low humidity, high temperature in the air conditioned atmosphere, and the pollution, especially at Lahore. We are getting a lot of smog these days. And most of the job requirement these days is using a lot of VDUs, screens, and the children in the COVID era are on line most of the time. And even in the mature age population, they have to use the screens all the time. And you can see at the moment we are all using the screens for this conference. So the modifiable factor is that you break your screen time, and we call it a rule of 2020, that for a 20-minute screen use, you at least look far away out of the window for 20 seconds. And you can also increase the voluntary blinking and increase the omega-3 and vitamin A in your food. And obviously a lot of supplements are also available, but the natural food is much better than the supplements. And we are lucky at Pakistan that recently we have got the unit dose of artificial tears launched by a pharmaceutical company, because the multi-dose bottle, although it is useful, but after a while the patients start getting problem from the preservative in that bottle. So the unit dose is better, and I'm a great fan of hyaluronic acid because it is more physiological and very much soothing for the patients. And if tear supplementation is not used and the modifiable factors, as I alluded earlier, not acquired, then this can be the unfortunate outcome that the cornea may develop ulceration and even perforation, and sequelae maybe loss of vision. Sometimes, other than dry eye, they develop inflammation in the ocular surface. If it is superficial, we call it episcleritis. If it is deep, we call it scleritis, which can be very debilitating because it results in a lot of pain, even so much so that the patient may not be able to sleep. And if it progresses, sometimes it can result in melting of the sclera and cornea, and again with a grave outcome. Sometimes these patients, they develop peripheral corneal ulcerations, and they may need a combined approach with the rheumatologist as well as the ophthalmologist working together. And uh, they may need sometimes the procedures to remove the conjunctiva, which is bringing all those inflammatory mediators. And obviously it is a big challenge dealing with these type of patients. Now the deeper inflammation is called uveitis. Mostly it is limited to the front part of the eye. We call it anti-uveitis. But in a study, it was noted that the prevalence is around 1/3. So 32% of the patients, they have anti-uveitis. And along with the systemic disorders, most of the time, we see ankylosing spondylitis. These are the seronegative arthritis, and HLA-B27 positive uh, arthritis, and Reiter syndrome and psoriatic arthritis we see. Behcet is not that common in Pakistan. The other big challenge is the juvenile chronic arthritis, because these children, although they have obviously a problem with the communication because they're young, but also we call it white arthritis because they don't have that much of the redness and obvious findings which can alert the parents. So it is an interesting presentation that more is the systemic involvement, less is the ocular manifestation. So if they have more of the systemic joint juvenile or idiopathic arthritis, then they have less ophthalmic manifestation. And it would be, according to the American Rheumatology Association guideline, they can be examined annually. But on the other hand, if they have ANA positive and there are less joint involvement, then they may get relentless uveitis, and they may have to be seen by an ophthalmologist every 3 months for the 4 years, and later on every 6 months for 2 years. They may go on with these recurrent attacks of uveitis maybe up to the age of 14 years, and then it becomes quiescent. And sometimes if the uveitis is not picked up, gradually they develop this band-shaped keratopathy, and the cornea become opaque. And also you see these inflammatory deposits on the cornea. We call it keratic precipitates. And the iris is inflamed, and it becomes sticky to the back of the to the front part of the lens, and we call it posterior Siddiqui. And they may have a lot of white blood cells which can pool down as due to gravity, and we call it hypopion. So these are the signs which may be even picked up by a rheumatologist, and they can be referred as soon as possible, so that we can give the topical treatment, and sometimes we have to give subconjunctival injection of depot steroids, or even sometimes the intraocular injection of the steroids. And obviously you are also controlling the disease with the disease modifying agent at the same time. Sometimes the complications are even more, that they develop cataract, and as well as there is blockage at the pupillary level, and they developed acute angle closure glaucoma. You can see in this patient that we had to do laser iridotomies to relieve the pressure. In systemic lupus erythematosus, there is less of the anterior uveitis, but it can have more effect in the posterior segment, and they may develop arthritis, and they may have the hypertensive retinopathy, and you can see that in the retina there are a large number of cotton wool spots. So if you have a habit to keep the ophthalmoscope, which unfortunately very few physicians keep these days, then you can see for yourself, and otherwise you need to refer these patients for periodic checkup. Polyarthritis nodosa, they also develop dry eye, corneal ulcers, scleritis, and retinal vasculitis. And there are a few patients, Wegener's granulomatosis, although it is rare, but those people who get it, they need on and off different types of intervention from time to time. I can vividly remember a very bright lady whom I shared the management with Professor Tafazal, and she was coming again and again with the dry eye, with cataract development. And at one stage, she developed the nasal problem, sinus disease, which was dealt by our colleague, ENT surgeon. And then later on, I had to do the dacrocystorhinostomy because her tear ducts blocked. But now she's still doing well. She's got good vision, and her Wegener's is also well controlled by Tafazal. So that was the example of dealing in a team. On the other hand, the drugs which are used to control the rheumatic disorders, they also enter into the eye through choroidal circulation, because that is a very rich circulation, and every drug which enters into the body is landed there. So they can have problems due to the drugs. Mainstay, I would say these days is hydroxychloroquine, because I see a lot of patients, and I'm lucky that the rheumatologist at Lahore, they frequently refer these patients for screening the side effects. The least they get is the corneal deposits. The other drug which is perhaps out of fashion these days, the gold injection which we are given previously, they also get deposited on the cornea. But the main challenge we get is the use of systemic steroids. They not only affect the whole body, but the eye as well. And these deposits at the lens can result in cataract formation, and that can affect the visual acuity in bright day and driving the challenge at the night time, because they get a lot of glare, and ultimately they end up having cataract surgery and intraocular lens implantation. And here are the example of cataract formation at different level. However, it has been noted that if the dose of steroids is less than 10 milligram, it is less damaging for the lens. Uh, on the other hand, the children, they very quickly develop cataract if they are given systemic steroids. Some of the drugs like anti-TNF, they are paradoxically said to be causing uveitis, although they are used to treat the uveitis. Now there are certain drugs which are used by the um, rheumatologists, like anticoagulants, and non-steroidal anti-inflammatory, and they can result in conjunctival hemorrhages and retinal hemorrhages. Conjunctival hemorrhage is actually quite common, and that frightens the patient a lot, although it resolves spontaneously. But if there is any doubt, and because some of the patients, they are having other comorbidities and they are on anticoagulant therapy by the cardiologist, so they need to adjust the INR levels. The anti-malarial drugs, chloroquine, fortunately we are not using that much, but the hydroxychloroquine, they affect the macular area and the typical bull's eye maculopathy, where there is perifoveal deposits. It can affect the vision to a significant level. And these days, whenever you want to start, I think it is better you get an ophthalmic examination. And we also go for the optical coherence tomography to exactly measure the foveal thickness and any pre-existing pathologies like age-related macular degeneration and other diseases, because the patient might have other disorder, and then once you start the drug, they may correlate it with the drug. So you can see in these pictures that the red area surrounding, which shows the area surrounding the fovea, has got less photoreceptors. So it is the initial damage due to a drug. Here you can see that there is hydroxychloroquine maculopathy, which started after a couple of months after starting the hydroxychloroquine, and you can see that there's a big dome formation at the macular area. And as soon as it was detected and the drug was stopped, you can see that in A, B, C, and in the last uh, quarter slide, that the macula comes back to normal position. So earlier detection can result in resolution of the disease, and we can also give the topical non-steroidal anti-inflammatory drugs which can help, and also the carbonic anhydrase inhibitors are helpful. Now, to pick up the early signs, you may ask the colleagues to get a visual field examination, and you can see in this test that there are scotoma in the central point in the bottom of this picture. Something which perhaps you can all keep in your clinics is an Amsler chart. You can download from the internet, and you can ask patient to examine this chart, focusing at the black dot. and then see uh, how the chart appears to you. The chart on the left hand side is the normal, it should be like this. But if there are areas in the chart which are missing, that means they are developing scotoma. Or if there is distortion in the lines, then that means that they are developing metamorphopsia due to the macular edema, and they can be promptly referred. Even you can give a printout of this chart, or they can use their computers to download this chart and monitor their own vision daily, or perhaps once in a week. Another very important early test which can be done in any clinic room is the color vision test. You can see that we are using the Ishihara test plate, but even if you don't have that, you can use any colorful picture, maybe a picture of the peacock or a parrot, cockatoo, which not only would relax your patients, especially if they're younger, but also you can monitor their color vision. You can also ask the patient to monitor their own color vision by looking at their favorite TV channel. Methotrexate is notorious to induce optic neuropathy, although very rare, but it is supposed to be related to the challenge in the folic acid metabolism. And obviously, it can result in irreversible reduction in visual acuity, color vision defects, and visual field loss. One should also remember that these sulfur-containing drugs, they have the risk of developing Stevens-Johnson syndrome. So any drug which has sulfur should be used with a bit of caution, because they may develop the lid problem, may end up having entropions, trichiasis, and very painful eyes. You can see here this one of our patients who developed the symblepharon following the attack of Stevens-Johnson syndrome. There are certain drugs which can affect the rise in intraocular pressure. Corticosteroids are notorious for that. And also, please note if there is any other comorbidity and they are taking any of these antimuscarinic drugs or beta blockers by the cardiologist, they may also have effect on the intraocular pressure. Again, Wagner granulomatosis can affect a lot of system as well as the eye. And last but not the least, the geriatric population is at risk of developing the giant cell arthritis. And again, here we have to work very closely together, the rheumatologist and ophthalmologist, because they have to be on systemic steroids for many, many years. So first of all, establishing a histological diagnosis is important. And for that, we use temporal artery biopsy with a caution that we may avoid the skip segment. And once it is confirmed, then we can start the systemic steroids. And obviously, you know all that you have to monitor the inflammatory markers during the steroid therapy. And if it is not treated at right time, they may develop optic neuropathy leading to optic atrophy, as well as central retinal artery occlusion, anterior ischemic optic neuropathy, and branch retinal artery occlusion. So they really, and if they have one eye affected, they're also at risk of developing same problem in the other eye. So we have to be very careful. Well, at the end, I would like to thank you all for being so patient and listening to this talk. And our purpose is that if we are working together, we can not only take care of our patient, we can provide them best outcome, as well as we can also support each other. And I wish you all very best for working together and disseminating knowledge in this challenging area of COVID. Thank you very much. Thank you all.